Okay, welcome back from lunch, everyone. If you could find your seat, we'll get started. We'll now begin our third panel. Our third panel is titled Shaping the Future of Precision Mental Health with Human-Centered AI. This session will explore how we can ensure that artificial intelligence becomes more integrated into mental health and remains grounded in human needs and promotes equity. I'm pleased to introduce this session's panel chair, Dr. Killian Pohl, who will guide us through the session and introduce the panel's speakers. Dr. Pohl is a professor of psychiatry and behavioral sciences and by courtesy electrical engineering here at Stanford, and is the founder of the Computational Neuroscience Laboratory. He's also co-director of the AI for Mental Health Initiative of the Department of Psychiatry here at Stanford, and he's been working in this domain for nearly 25 years. Dr. Pohl's research is grounded in computational science using machine learning to identify biomedical phenotypes from high-dimensional neuroimaging, cognitive, and behavioral data. Dr. Pohl is a leader in computational neuroimaging and in developing advanced methods to better understand brain structure and function in mental health. Please join me in welcoming Dr. Pohl.
Thank you so much for being able to host this exciting panel with three exciting speakers that have very complementary research backgrounds and give us their perspective on how to use AI for precision medicine and especially depression. The first speaker is Dr. Hernandez-Boussard, the Associate Dean of Research in the School of Medicine and Professor of Medicine in Biomedical Medicine, the Biomedical Data Science in Surgery, and by courtesy of Epidemiology Population Health Sciences. What you might not know about Dr. She's already laughing, Hernandez-Boussard, is that she is a retired barrel racer and calf rider. Beyond that, her work centers on creating rigorous criteria and guidelines for developing responsible AI. Furthermore, Dr. Hernandez-Boussard strongly advocates for ensuring that the benefits of digital health technologies are accessible to all segments of society. Today, she will speak on advancing AI research, education, policy, and practice to service the collective needs of humanity. Dr. Hernandez-Boussard, the floor is yours.
Good afternoon, everyone. Thank you so much for this opportunity to be here. Thank you, Leanne, for this amazing gathering of our community. And I think it's just so wonderful to bring all of these diverse research opinions and ideas together. So today, this afternoon, I guess we are, I want to talk about kind of bringing in a lot of the things we've heard this morning to think about how do we think about the future of mental health in this explosion of AI, right? There's a lot of hype about what AI can do for mental health. And we've seen it across the cognitive work we saw this morning. We've seen a lot of this behavioral work, cognitive therapy. So where does that bring us? And how do we think about using AI effectively and safely in mental health? So there's a lot of promise, right, about what AI can do. And there's a lot of, recently we've seen a lot of like mental health chatbots coming online and coming out and being available to our community. You know, it's great because one, they offer 24/7 support, right? They are available all the time. 3 o'clock in the morning, I need to talk to someone. Hey, there's an AI chatbot available. It's lower stigma. I don't have to be embarrassed. I'm talking to an AI bot. So it lowers the stigma of how we can talk to these people. And also accessibility, right? I can be in, so I grew up, I did grow up barrel racing in Central California, which is a very remote area. Closest, town is probably 4 or 5 hours away. So accessibility is huge with these AI chatbots, right? But there's also a fundamental lack of oversight on these tools, right? So these tools are being scaled out to our community, to patients, to patient-facing apps, but there's really no oversight on what these tools do, how they do it, and how they were developed, right? And so this is because they're working in a regulatory vacuum. And what do I mean by that? So most tools need to go through the FDA clearance if they are informing care, if they are driving care decisions, or if they're actually developing a treatment or a diagnosis for a patient. So anything under that toolbox needs to have an FDA approval or some type of regulation. But these AI chatbots, they are coming under the avenue of their wellness apps, right? So they're not doing anything with medical care, they're helping you with wellness, right? So what are they doing? They're helping you with lifestyle choices. They're helping to promote and track your choices. And so they're making some general claims, but they're claiming it's not medical. So therefore they start without this regulation, but then slowly but surely we're seeing them inch into the medical space. And why is that? Well, because, you know, our healthcare medical system is a multi-billion-dollar entity, right? So of course they want to move into that space. But again, there's no regulations on these AI chatbots. And so that means that we see some of these horrific stories that have been coming out in the news, where we have teenagers who have been talking with these AI chatbots. And in some of these cases, this is just one, devastating, where, you know, the AI chatbot might have given them some information on how they might attempt suicide. What are some avenues they might think about? So this is devastating, right? And I think that this is a community that we really need to think about. How do we think about the boundaries of AI? And how do we think about really safely deploying these tools, leveraging the hype and the super potential of AI, but yet doing that in a way that is very safe and effective for our healthcare system? And so I think that we need to think together about some better ways to harness AI for mental health. And we've seen some excellent examples this morning, again, about some cognitive information, how we're using AI to look at brain imaging. How do we pull that together and merge that with things like these AI chatbots? Anybody thought about that? Well, we've been thinking about the patient digital twin and what that can mean for mental health. So what is a digital twin? We've heard it probably in very different scenarios. We've seen it in engineering, in the aviation industry. We're even seeing city digital twins. So what is it? It is a virtual replica of a system. That system can be a city, it could be an airplane, or it could be a person. And so what's unique about a digital twin is that it really breaks down the silos that we have in healthcare. That means it incorporates multi-scale, multimodal data across a diverse time frame. So we take the cognitive data, we take the behavioral data, we take the environmental data, we take social determinants of health, and we try to normalize all that data. So instead of having 5 separate models, we bring them all together in one model that is very precise for you as an individual. And then we integrate that till we say, you know, how will you personally react to treatment A versus treatment B? How do we integrate this into point of care so that your clinician, your therapist, really has the dynamics of your personal biology coupled with your environment, your accessibility issues, et cetera? And so again, this is about multimodal information. It's about capturing patient history, patient characteristics, genomics, social determinants of health, and mechanistic models. And so this is something I want to just pause on just for a minute, because we've heard a lot about these mechanistic research endeavors that have been going on in mental health. And then we hear about our data-driven models. How do we merge those together? And I think this is sort of the sweet spot of the digital twin. And it's not just clinical history, right? It's really biology. And so let me give you a clear example. We do a lot of work in pain management and how we think about identifying optimal treatment for pain management. Did you know that if you are taking an antidepressant you are less likely to respond to about 90% of opioids because antidepressants block a liver enzyme that is necessary to activate opioids in that need to be metabolized. And so if we don't take these two pieces of information together, that means that the patient's not going to be respondent to the pain management cases. That means they're going to need more opioids. They're going to need more pain management because we're not giving the right treatment for that patient. That means they have higher risks of having misuse, of becoming prolonged users. And so it's a very simple piece of information. It's just they're held separately in separate domains. So we think about how do we pull this together? So another piece that we're incorporating into these models are really thinking about uncharted data evidence. And so it's hard to say uncharted at Stanford because the speaker before me just talked about using voice data, okay? So I'm going to still call it novel because there's not a lot of models that use it, but we're capturing voice data everywhere. We have ambient AI that's picking up and recording voices. And so there's now new research that shows if we incorporate this into our data-driven models, we can detect early signs, early differences in patient pitch, in speech patterns, in different aspects of speech. And using AI, we can pull these together and then match that with your smartwatch, your physical activity. Well, your pitch is going down and I see your activity is going down. And wait a minute, you're taking this type of medication. And so we can start pulling that all together. And what does that mean? That means we have the power of forecasting how you might respond to treatment A versus treatment B. So let me give you a clear example of that. This is Maya. Okay, Maya is a teacher. She suffers from mild depression. And so she went to her doctor to get, some treatment for her depression. So they initially started her on an antidepressant, an SSRI. And so with that, she had some sleep improvement, but minimal mood changes. So then she switched to a different antidepressant, right? And so she got rapid energy gain, but she had new anxiety and jitters. And so it didn't work when she was teaching. So then she went into cognitive therapy, right? Therapy number 3. And that helped her cope with negative feelings, but it didn't really get her to where she wanted to be. So finally, they started her on a low-dose antipsychotic and her suicide thoughts reduced. And this was a great treatment for Maya. But this was over 12, 13 months of time for her trying, trial and error of these different treatment patterns. So imagine if we can say that we can predict before she starts taking that therapy how she might respond to treatment, the antidepressants versus the antipsychotics. Imagine we could show, okay, well, here on antipsychotics, we see that you have a significant decrease in depression, but maybe not a big decrease in anxiety. Imagine we can say, look at on antipsychotic or on SSRIs, we see not a real significant change in both depression and anxiety. This is where we are when we start thinking about the possibility of the digital twin, really being able to forecast how somebody might react to a different treatment pattern so that they don't have to go through the 13, 15, 18 months of trial and error, which can mean life or death for a lot of these people, right? It's really important to understand how we reduce that trial and error period. However, and more importantly, I think this allows us to shift from reactive care to really proactive care, right? And how does this matter to the patient? Because it allows the individual patient to identify what's important to them. Is it the anxiety? Is it depression? Is it all these different aspects that these treatments treat differently? It allows them to compare the benefits and harms of different types of therapy before they start, before that 15-month trial period. It also allows us to identify potential risks so that we can be proactive before they happen. And it really integrates all of these different disciplines, psychology, behavior, environment, social determinants of health, into a single model to allow us to do this forecasting. But, and it's also important to say, this is not a virtual you that you're going to take along with you to the park, right? This is really a tool, a co-pilot to help clinicians, therapists, caregivers understand what is the best treatment pathway for you and what needs to be considered when you're taking these different options. And it's about building trust, right? Which is fundamental in this field, right? It's fundamental to gain the trust of our end users that we actually are thinking about these different benefits and harms. But this can't work without governance and without some type of infrastructure, right? And so we've done a lot of work thinking about what does it mean to have a responsible AI in any field, in mental health, but in all other fields. What does that mean? And one thing I think that is really important that I've learned is it's not about the AI hype. It is not about how well your model performs. Yes, that is important, but it also depends on how did you develop your model? Who was your model trained on? So who is it applicable to, but also who is it not applicable to, right? That's really important to understand where you can apply these models. How do we think about getting it into point of care? And where does it go? Does it go to the clinician? Does it go to the nurse? Does it go to a patient-facing app? So all of these pieces are really important when we think about governance. And so we've been working for tools that are actually deployed in the healthcare system. We've been working with a team between Stanford and Harvard, thinking about this framework for deploying that's really, number one, focused on safety. How do we ensure the models are safe before we even bring them to point of care? How do we think about their effectiveness? What do we see when we start deploying them in a few clinics? How do they work? How well are they changing either treatment or outcomes or something? What's their efficacy, right? How do they work? We roll out to larger communities. And then more important, how do we think, once that model is deployed, how do we think about monitoring and surveillance of the tool? How do we ensure that population changes aren't changing what happens to the outcomes or the predictions of these models? And so I want to bring the attention to an FDA convening advisory committee. And so this is really important because this is the first advisory committee that the FDA has had in a long time this year. And it is going to be focused on generative AI and mental health devices. And so I'm excited that I've been tapped on the shoulder to help this conversation and to help think about what are the guardrails we need to put in place that do not stifle innovation. So we still want the innovation, but they have guardrails. And so we're coming up with some sort of chatbot core minimum requirements regarding, intended use and risk identification, crisis safety, age gating. We've talked about age gating previously. Transparency. Who was the model trained on? We did a survey of the 19 publicly facing chatbots, and some of them were trained on like less than 200 people, or safeguarded on less than 200 people. It's crazy. And so this is a list of requirements we're putting forward to the FDA for their committee meeting. And I just want to say that it's all about transparency and explainability when it comes to AI in health. We need to understand how the tool works and who it works on. We need community co-design. We need to enforce insight, right? Ensuring these safeguards in place. And it's really about interdisciplinary stewardship. So thank you so much. I hope I gave you a nice overview of, what the future might hold. And I think we have a lot more discussion to come. So thank you so much.